Good afternoon.
Kira.
Hi, Rebecca. Hi, Shannon.
Hi.
Hi. Just
Um, James, I can't do any chat in my computer. I don't have a chat option. So if you want feedback, do I just put my hand up and then?
yeah, you could. That'll
Yeah.
be fine. Yeah. Cool.
Mhm.
Hi, Lee.
Hey James, how are you?
Yeah, good. Thank you. Um, so just waiting a couple more minutes for people to log on. I will get my presentation up. Today we're going to talk about the science of human factors. So just the next module in patient safety. How are people getting on with the online modules? Have anybody got any problems? No? Doing well? Great. Excellent. Well, if there's any problems, you know where I am. Shannon?
Just I had done halfway through a module and then I went on leave and when I came back it had been wiped. So I had to start over again. So I'm a little bit behind still, but that's fine. It was my own fault. I just aimed to finish them.
Yeah, sorry. I think they were doing some upgrades at some point
Mm.
and they put a warning saying that any half-finished stuff will get wiped. Sorry about that. Okay, so the science of human factors. So human factors is basically the study of what humans do in our systems to make them dangerous and how we can control for that. Because we can never remove the humans from our systems, mostly anyway. And so we need to allow for the limitations that we have so that we can make sure the system is safe. I'll be diving into human factors and we will discuss how to mitigate the effects of these factors and talk about the different strategies that are available to doing that. So why does it matter? Well, it's a bit like healthcare workers who do not understand the basics of human factors are like infection control professionals who do not understand microbiology. It's as fundamental as that, really. But for a long time, there are plenty of people who go about their business and are not really sympathetic to the fallibility of humans. You know, if something goes wrong, then someone is to blame, and they should try harder to not do it again in the future, which works for some situations, but is not the answer to everything. We need to be aware of the common types of cognitive errors that can help clinicians recognize and so that we can help clinicians, but not just clinicians, all healthcare professionals recognize and avoid these cognitive errors. So just a recap on errors. Errors are things that happen in either an action that was planned, but it was wrong action to begin with, or the right action, but it went wrong. It was actually executed wrongly. And things that don't go as intended are slips and lapses, and things that was the wrong action to begin with would be a mistake, either due to a deficiency in knowledge or a deficiency in applying that knowledge correctly. So there's two types of ways in which we commonly make decisions throughout our day. And most of the time it's automatic thinking. It's heuristics. This is what the human brain has evolved to be able to do very efficiently for survival reasons. So to make a split-second decision on what to do if that tiger comes chasing after you, that's all automatic thinking based on experience. So the more we experience a certain situation, the more likely we are to instantly react in the right way. Of course, if that situation is just slightly different to all your previous experience, then you might not notice the difference, and therefore the split-second decision you make may end up being the wrong one because you've not quite noticed all the detail. So that's the main downside with automatic thinking is assuming something fits a previous pattern, but it actually doesn't. So it's prone to errors of execution. You do something in a split second and say it's the right thing, but because you're trying to act so quickly, you end up not doing it quite right. Controlled thinking is quite the opposite. So that's where you take your time, you take in all the information, you weigh it up logically, and you think through the problem and you make a decision, also called slow thinking. This is prone to errors of planning. So this is where you don't quite put all the complicated bits of the puzzle together and you come up with the wrong decision because either you didn't have all the knowledge to begin with, all the inputs, or you put it together in slightly the wrong way. Is there anything in this picture that you wouldn't drink? Give you a second to look at it. Did anybody spot anything that you wouldn't drink?
Like there was something that you might wash your clothes with.
Yeah, some Tide detergent. Yeah, good. Anything else?
There was another product on the right. I'm just trying to remember what it was. Was it bleach or something? Yeah.
It was a baking soda.
Baking soda. That's
Baking soda.
Yeah.
Well done. Okay, so you two saw that as well. So yeah, the Tide is quite obvious because it's in a bottle that looks like detergent. So when we're looking at this picture, we kind of make some. We can't read all the labels quickly enough. You know, I didn't give you enough time to do that. So you make some assumptions based on the color, the shape of the bottle, and the general sort of vibe that it comes from the packaging. But this baking soda looks like it could be, I don't know, a dessert spread or something, you know. It doesn't come in a bottle that looks like something that because it's actually a product for cleaning. It's not even food grade baking soda. It's for cleaning. So that packaging doesn't align with what we would assume a cleaning product to look like. And so that's an example of heuristics. You know, you're having to make quick decisions based on patterns because there's not enough time to do slow thinking. But as I said, we miss things. And other examples in healthcare would be, you know, a doctor sees an unconscious patient in the ED and they smell of alcohol. So they assume that their reduced consciousness is due to being inebriated. And they forget or they miss the fact that the patient actually has got hypoglycemia. And not only are they drunk, but they're also diabetic. Or a pharmacist just grabs the wrong packet of stuff and delivers it because it looks very similar to the medicine that they were actually intending to get. Or a nurse ignores a critical alarm because they're just going off every 10 seconds and so they become background noise. So there are there are several factors underlying which will make us more prone to error. Okay, so what may they be in these situations? So a physician diagnosing a patient, or a pharmacist filling in an order, or a nurse delivering a treatment. What sort of underlying factors can make these errors happen more frequently? So you have internal factors. So that's things like psychological and physiological states. People who are tired, stressed, hungry, really don't think clearly compared to those who are not fatigued, not stressed, not hungry. Illness as well, general attitude, and also your own sort of memory. People may have memory problems, which would affect their ability to do something correctly. Then you got external factors. So things like noise, light, temperature. Some people can't concentrate with background music. Other people find silence distracting. So it can be quite personal. Certainly if you put someone in front of a computer and tell them to work for 8 hours a day and the temperature is 12 degrees, I think they will find it difficult to maintain full concentration. So the environment is really important. Then there's the obvious things, distractions. So like if somebody's constantly tapping you on the shoulder saying, oh, please do this, please do that, whilst you're in the middle of trying to administer drugs, you might administer the wrong drug. And then we've got cognitive biases. So these are beliefs that we inherently hold, and they are part of pattern recognition because it helps us make quick decisions. And so we have biases towards certain decisions. For example, if I'm a surgeon, or I am a surgeon, and I think that operating is the best treatment for this patient, that's because I've done lots of the same operations and I've seen the outcome and I know that it works. But there could be another doctor, say an oncologist, who treats the same condition with radiotherapy, and they also see good results with radiotherapy, etc. But each of us, we don't know intimately what the other treatment is like, and so we have a bias towards offering the treatment that we are most familiar with and we can talk about, and we know the ins and outs, we know the pros and cons, whereas offering the radiotherapy for me as a surgeon is a bit more difficult to put my full endorsement behind, for example. So that's just confirmation bias. That's just going with what you are familiar with. Yeah, so there's lots of factors that can make us prone to error, basically. And how can we prevent errors? Well, as I said right at the beginning, vigilance and hard work can be effective, but it won't get us all the way. There are certain things or certain times where trying harder just won't really deliver better results. And this is where human factors engineering comes in. It understands where the limit of people's performance is, and then we design the system and the environment around to make it less possible for risky and wrong things to happen. So the principles of this engineering comes from anatomy, physiology, physics, biomechanics, and also a lot from psychology as well. So a really good example in healthcare would be anesthesia. Anesthesia was quite a dangerous thing for a long time, where 1 in 5,000 people would die. And now it's so rare for a death under anesthesia that we can pretty much say to most people that they're not going to die from anesthesia. And that's funny because the public still have a perception that anesthesia itself is quite risky. And you know, when you talk about the risk of death in surgery, they often say, "Will I wake up?" And then you have to reassure them that yeah, you're going to wake up. The risk of death comes afterwards. Yeah, so and the reason why anesthesia has become really very safe is due to many, many years of methodical standardization and protocols and changing of equipment and redesigning it to be safer and safer. A lot of the principles have been taken from aviation. So examples would be like the valves. They used to turn different directions to turn them on and off. And so I think I remember hearing one story of a patient who woke up brain dead because the oxygen had been turned off. And that's because that particular anesthetic machine, the knob went the opposite way. I think that's quite a famous or infamous example. In anesthesia, there's lots of checklists now. They check the anesthetic machine before the list, and that goes they actually go through a checklist to check all that. A bit like when you're in the cockpit before they take off, they check through all the things on the airplane. Promoting teamwork by encouraging nurses and others to speak up. So this is about flattening the hierarchy. And again, this comes directly from aviation, where in the cockpit there used to be quite a steep hierarchy gradient between the pilot and the co-pilot, and it would mean that other members of the flying team would not speak up if they thought there was a problem. And then a lot of culture work has gone to flatten that hierarchy, so people feel free to say any concerns that are on their mind, because at the end of the day, they want to keep the plane flying. I guess the one difference we have between healthcare and aviation is that in pilots, they have a personal interest in having a safe flight, because if the flight's not safe, well, they could end up dying themselves. Whereas in anesthesia, the anesthetic doctor is usually not suffering the same fate as the patient if an error occurs. So I guess that's one major difference. So once we're aware of the limitations of humans, then we can think of ways to prevent these errors. And there's lots of ways. So simplification is a really good way. It's removing unwanted or duplicate steps to make a process much easier to follow, easier to remember. Standardization, making it the same every time. And not just the same every time for this for the one department, but across the hospital, across the district, across the nation, across the world. Standardization means that you more easily fall into the same pattern of working every time you approach the same problem. Avoiding reliance on memory is a big one. In medicine anyway, at the moment, we still rely heavily on memory. Especially when it comes to diagnosing a patient. We still don't collect data and put it into a big box and then get the answer spat out to us, but maybe that's the way we're going with AI eventually, where AI will be better than doctors at diagnosing. But yeah, if that doctor can't quite remember the 14 different symptoms of some vague syndrome that only occurs 1 in a million, then they're not going to reach that diagnosis, even if it is the correct one in that patient. So memory is still a big part of medicine, and we need to try and get away from it to a certain extent. The downside, obviously, is that memory is very quick. It's very fast. You can access it very quickly, whereas if you're relying on external knowledge, from the internet, from books, from other people, it suddenly is a lot slower in getting that information. So improving access to information is the opposite of that, basically. It's making information at your fingertips a lot quicker, a lot easier. And certainly I think that's where AI will come in, because then it can basically deliver you a tailored result to your question. Taking advantage of habits and patterns. So we all sort of do something automatically, and if you can tag on a new positive behavior onto something you're already doing, then that will mean that it's much more reliable. It happens every time you do that other habit. Forcing functions is probably one of the hardest in terms of like interventions. One of the hardest, one of the best interventions you can do. So forcing function prevents you doing the wrong thing, unless you do the right thing. So, for example, if there's a call bell on the wall, it is possible to, if the call bell on the wall was a button that you pushed in, then it would be possible to accidentally lean against that and set it off. So the call bells are all pull buttons. You have to pull them away from the wall for it to activate. Now it's almost impossible to lean against that button and make it go off. So that would be an example of a forcing function. Visual controls, it goes without saying why. Effective team functioning. So this is mainly around communication, because as we talked about earlier in this talk, a lot of errors come from deficiencies in knowledge or deficiencies in applying that knowledge. And a team operates, the main way a team operates well is that they're able to share knowledge within the team very well. So if you can improve the communication within a team, then you can actually improve the overall performance of that team. And using redundancy. So this is where you have a safety net, you know, or you do something twice. And then eliminating external factors that degrade performance. So making sure we don't make people work 24 hours a day, 7 days a week. Make sure they get some rest. Giving them annual leave would be one way to reduce fatigue, being an external factor. The district provides counselling services free for all its staff for anything that they are experiencing in their personal life. And that is a way of trying to reduce stress or sources of stress in our staff, which then are external factors that can lead to poor performance. So these are all sort of ways in which we can change the external factors, and then creating systems that are better able to tolerate errors. So a system that you might put in something wrong, but then it will say, hang on, this is wrong, please correct it before it goes further. So here's some examples. I'll give you a few minutes to either put in the chat what you think these examples are, or just write it down on a bit of paper to yourself before I give you the answers. So can you tell me what type of what this example is a strategy? So these strategies are a list of them, and if you can't remember exactly what they are, just kind of just remember in your own words or what they're trying to do. So what types of strategies are these? So double checking someone's work, a computer alerting someone of a potential error, removing a step in a process, storing things that are used together in the same place, and a system that requires a piece of information to save your work. Okay, here are the answers. So the first one was about redundancy, double checking, doing something twice. The second one is about building systems that can tolerate errors. So the computer will accept what you put in, it will then check it and then tell you it's wrong, please correct it. The next one is simplification, so removing a step in the process. Storing things that need to be used together in the same place would be taking advantage of patterns and habits. So if you need to cannulate somebody and put an IV cannula in, it makes sense that we put all the stuff they need for that cannula in the same place. And then people worked out that it would be even quicker if you made up these pre-prepared these packs with a bag that everything you need it for one cannulation is in there. So you go to the storeroom and you just grab the bag and you go, rather than going to the storeroom and picking out all the individual things into your own tray and then going. So that's an example of making it easier. And then the last one was a forcing function. So you can't proceed until you've put in that piece of information. So people often look towards technology as a solution, and it can be in a lot of situations. But this is one of my sort of bugbears about technology, is that it's the first thing that people think of usually in a situation. And the problem is that technology is always far more difficult to implement than you imagine. And then it actually creates different problems that you didn't think of in the first place. We've got classic examples of them, but one would be MedChart. So MedChart is an electronic prescription chart that replaced the piece of card that is at the end of everybody's bed. So before, it was quite easy to just pick up that paper card and write down your prescription, sign it, and then the nurse would use the same card to record when they administer the drugs to it. So the pros of this system was very quick. The information is there at the bedside when you need it for reviewing a patient. It was very flexible. You could write anything on that drug chart. So long as it was available, it would come. The downsides to the chart, well, if somebody took the chart somewhere else, then it was no longer available and you would waste time looking for it. If the chart went missing, then you would need to write a new chart and there would be potential errors introduced by represcribing a new chart. Legibility was a real big issue, not being able to read, or more importantly, mistaking one dose for another because of the handwriting. So there's lots of inherent risks with a paper chart. So MedChart is an electronic version of that. The pros of an electronic version is that it would make sure you're not prescribing a dose that is incorrect. It would check for interactions with other medications already prescribed. The chart would never go missing. Therefore, it would be easy to refer to if the patient came back in and you want to see what they were on previous medication, and lots of other advantages having a computer look after this. But there are some big disadvantages that it's introduced that are definitely worse than the paper system. So one is availability at the bedside. Trying to get MedChart to work at the foot of somebody's bed in some areas of the hospital is impossible because we don't have Wi-Fi connection. We also have very aging laptops which run very slowly and don't load it up quickly. So if time is an issue, then reviewing the chart often gets missed. So although we've fixed some problems with technology, we've actually gone backwards and introduced risk in other areas. So unless technology is very carefully implemented, then you're often just swapping one set of errors for another. The best technological systems in the world are the ones where it makes it easier for you to do the thing that you wanted to do and it doesn't make anything more difficult. So then there is an effort gradient where doing the old thing is more difficult than actually doing the new thing, and then you'll see that there's rapid adoption of that new technology. So yeah, technology is a double-edged sword. And so when it comes to improving something, really don't start with a technological solution. Start with the process. What is the process that needs to be improved? And you'll actually find that there is a paper-based solution to your process. There's even if you're going to implement a computer-based system, it's good to think of what would the paper-based system be like, and how can we make that work. Then we need to test it, obviously, and we should make sure that we're not over-reliant on technology, although we really are nowadays, because if the computers go down, that is a a serious incident that can actually stop the hospital working safely. If all the systems go down today, elective surgery would be cancelled, outpatient appointments would be cancelled. Basically, a lot of things would stop working straight away. Okay, so now we're on to just having a look about a video about sampling. So I'll just play it and then we'll discuss it afterwards. I'm just going to make sure we can hear. So I'm just going to. Oh, just need to work out how I do this again. Oh, I've forgotten how to do it. It was hidden somewhere in Teams. Can you hear that? Yep, great. Okay, so that was an interesting video, and there's a few sort of discussion points here. When designing a reliable process or system, why does Frank recommend starting with a small test? Well, he recommends that because it's easier, and if you can't do it on a small scale, then you're going to really struggle on a large scale. Has anybody ever started to test an idea and wish you'd started a lot smaller? Has anybody got any examples they'd like to share? Yeah, I mean, in my earlier sort of quality improvement learning, I wanted to do a project for just coursework for my course that I was doing, and I decided that I wanted to improve the whole pathway for patients with cholecystectomy, and I thought that would be easy enough, but it turned out that was a very, very big um, circle around a lot of things, and I could have focused on just one particular aspect of it instead of doing the whole thing. It was fun, but the whole project itself took me a whole year just to get data, basically, get information from the system about what all the problems were, do a focus group to find out from the patients what their experiences were, etc. like that. And I ended up writing 3 big reports about it. And then I had to, that was my time up. So I gave those reports to the organization, and they didn't do anything with it. I think they listened to it, and they were still like, this is amazing work, thank you very much. But that was the end of that, because I hadn't really thought about anything like sustainability and who's going to take this on and who's going to do all these improvement things like that. And that's the same as any sort of consultants that we pay lots of money to come into our organization and tell us what's wrong with it. They take some time. They really do a thorough job of diagnosing the problem, give us a report, and then nothing ever happens and nothing changes. And those are all examples of starting too big. It really doesn't matter if you know the full size of the problem. If you're not going to fix it in the first place, there's no point having a nice shiny report about it. So I'm really much all for thinking about, okay, think much smaller, think what small little incremental things you can do to improve in a short amount of time, and that it goes along with that sort of that common saying, whereas you usually overestimate what you can achieve in a year, and you usually underestimate what you can achieve in 5 years. So that's why people always start off too big, is because they think they can achieve it in a year, and starting off too big means that you end up stagnating along the way, maybe not even making it, and things don't happen. So that's a year of wasted time, basically. May as well not have started at all. So yeah, I think it's really important to think much smaller than you would do initially. So maybe think of a daily process in your work or school and what population is involved. And if you wanted to make a change to that process, what subset of the population would you start with? So maybe think in your area of work, what sort of population do you commonly engage with? So if you're patient facing, then that will be, who's your patient cohort? Who do you usually see? Or if you're not patient facing, then it'll be like, who are your internal customers? Who are the people who come to you all the time for either your help or your advice or whatever. So think about your own population, and think about what do you repetitively do? What do you commonly do in terms of with these patients, and are there any processes that you do over and over again. So if anybody's got any examples of a process that they do with their population, you might be able to, you want to share it with me? So in my line of work, one of the things I do is I see patients in clinic, and I put them on the operating list to do an operation. So that's a quite a straightforward process. You see a patient, you assess them. So you're thinking about the process diagram that he was drawing up. If I had 5 boxes, I would say assess patient would be the first box. The second one would be booking for surgery. The next one would be assessing safety and suitability for surgery. Then the next one would be consenting and preparing for surgery. And then the last one would be doing the surgery. Okay, so those would be the 5 steps in there. And in terms of the processes so far, we've got pretty good processes at identifying and assessing patients and deciding if they are appropriate for surgery. That's what I went to med school for. So our processes around that are pretty good, so we don't need to improve that. The next one is booking a patient for surgery. So I would say that this is probably a pretty poor step in our flow there, because we have all sorts of problems with booking. Identifying gaps are in the schedule to put them into, identifying if it would be better to schedule them with a different surgeon because they get their operation quicker, or whether it's actually best to wait longer and get operated by me because of certain clinical aspects. The booking stage is part of the process that would probably need improvement. And if I was to pick one sort of thing within that booking stage, it would be the fact that we still use a paper form to do the booking. Now, our paper system is well established, and I don't think we could make it much better as a paper system. So this is actually one example of where technology would improve it. And so how would I make that technology better than the current paper system? Because paper is very quick and efficient, and it's flexible. Well, what I would probably do is make a system where you could somehow the system would already know what the patient is, who the patient is, and what they're coming in for. And if you just put in a few bits of information, it might actually be able to tell you, okay, your next free slot is here, or somebody else's next free slot is here. They would be able to do this. And so it would actually help you find a booking time. So that would be better than the paper-based system where you have to manually look through everybody's diaries. This one here would automatically show you. So that would save you time. It would make it easier. It would make people more likely to use that system. So that's one example of taking these principles, and then how would I take a subset of that? Well, then if I wanted to try that new electronic system, I wouldn't just roll it out across the whole department straight away. You would probably just test it out in one patient to begin with. You test that in one patient, then you go speak to everybody who is using this new system and ask them what was good, what was bad. You change it, and then you might try for another one patient, or you might try for the next week, and you might book a couple of patients that week, and then you would go back and you would slowly, incrementally improve this system until it was definitely better than the current system, and only then would you then start to roll it out, so to speak. So so that takes me to the end of the talk today. Has anybody got any questions at all about human factors? Great. Well, I'll let you get on with the rest of your afternoon. Thank you very much. Cheerio.
James,
Thanks,
can I
James.
ask you one
Yeah,
question
sure.
about human factors?
Yeah.
Let's say you were going to survey your staff. I mean, what questions would you ask to find out, I don't know, about okay, what I have is a problem with nurses recognizing and responding to deteriorating patients
Yeah.
until they have well and truly deteriorated
Mm.
and actually end up in ICU. Everybody else is here. So really trying to figure out what is going on.
Yeah. Okay. Very good. Very
So,
good question. So the problem is that yeah, so if you were to think about that flow chart, you know, in treating a deteriorating patient, the first box is recognition, isn't it?
yes.
Is acknowledging. So, and that's where you're at. Um, yeah, you might want to start off with a survey, because you need to get all sides of the story, don't you? You need to find out from your staff. Now, you could develop a questionnaire if you got lots and lots of staff and you wanted to get as many people answering as possible. But if you don't even know what to ask in the first place, then probably the best way to start off is actually not a survey,
Right.
but
Okay.
a series of interviews. So you sample your population, because you can't interview everybody, that's too time consuming. But you sample your population, and there's many ways to sample. There could be random, but I would say the best way for a qualitative investigation is purposive sampling, which is basically you choose
Okay.
based on what you want to find out. So you probably think, okay, what types of nurses do I have? I have some new grads, I have some experienced ones, I have some international ones, and I want to know from all of them, all of those different types of people, what their problems are. So I would sample to make sure you touch all those different groups. I would then go in and have a couple of open questions listed, ready to ask them, maybe 3. And I think 3 is enough to take you into a nice discussion of the ins and outs. So you'd ask the same 3 open questions to your group, but then you would let the discussion go wherever it goes. And you write down that, and from that you will start to get some common themes.
Okay.
And once you've got an idea of the common themes, that's when you can start to narrow down your investigation on, okay, which problem is the biggest problem? And that's where you can then maybe send out a survey on a much narrower idea. So for example, say a common theme came back was, I've not been trained on this at all. Then you would then start to survey on, okay, what training were you offered? Did you attend it? Did you not get it? You know, what went wrong? Or did you go to the training? How come you don't understand? Or where is your lack of understanding based? And there you can start to get down to why they're not getting trained properly. So that would be one sort of particular problem. And then once you're sort of like getting down there, then you can start to think of experiments to improve the situation. Okay, so if it was training, and if the training problem was to do with the fact that training is just too few and far between, then is it better to have a 5-minute mini education piece at the beginning of each handover, where you know, if you were going to do a PowerPoint presentation for a whole hour, okay, in that 5 minutes, which is the one slide that we would talk about today?
Okay.
So a drip feeding approach rather than a one-stop approach, maybe that might work. Who knows? It's just thinking off the top of my head, but you could also brainstorm ideas with your staff themselves. Yeah.
Thank you. Great. I'll be doing that.
All right.
This
Great.
week.
Okay then.
Thank you
Good.
very much.
Any other questions?
Oh, good. Thank you very much.
Right.
Appreciate
Great.
it.
Cheers.
You're welcome. Okay. Cheerio. Bye.
See you all.
Bye.